Good evening, friends. Can I have the first slide? I think Dr. Vishal has spoke wonderfully about cancer and its what we are going to probably see in the future. I would like to stick to the present, what we, what is the present problem, and how probably we are may be able to deal with it. You know, as he said, oncology is a field where it affects nations across the world. Age is not a bar for cancer to develop. It's a disease of the aging, basically. As you grow old, there is higher risk of developing cancer. And it's all over the world, but the pattern is different. Maybe in developed countries, you'll see breast cancer, colon cancer, ovarian cancer in a higher incidence, which is quite high. Whereas in developing countries or underdeveloped countries, we see oral or head and neck cancer, which is related to habits like smoking, alcohol. We see cervical cancer, which is again related to multiparity, infection, other things. So the same pattern we see even in India, and I'm sure that you will reflect it may be the same in your country too. So in urban areas, there is a pattern, and in the less economically developed areas of the country, there's a different pattern of cancer. Now, I was told that I have to speak on radiation therapy in cancer. So now, as Dr. Vishal told that there are four major components in cancer management. When you diagnose a cancer and after you stage it, whether it's first, second, third, and fourth stage, you have to decide what is the treatment modality for cancer. So we have surgery, which is a very important role in oncology today also. Then we have radiation therapy, which is where we give very high energy X-rays to kill the cancer cells. And then we have chemotherapy, which takes care not only of the area of what you see, but you are giving it in the bloodstream. So hopefully it will kill cells which we don't see also, what we call as micrometastasis. Although PET scan is normal and all scans are normal, say suppose in a breast cancer, we still give chemotherapy. The reason is we feel that there are cells in other areas of the body which may come back after 6 months or a year or so. So we prescribe this chemotherapy, what is known as adjuvant treatment. So these are the main four areas of onco treatment, and radiation is one of the important role in cancer management. The starting of radiation was more than 100 years back. It has been started to be used for treatment of cancer. And 75% of the patients having cancer, that is out of 10 patients developing malignancy, 7 or 8 of them will require radiation at some point of time in managing the malignancy. That means if you have a cancer center in your country, you should have a radiation machine. It's important because 70% of the patient will require radiation. So it will be incomplete if you have a good surgeon and a good oncologist or a chemotherapist to give chemotherapy, because you wouldn't have radiation, then the risk of relapse, etc. will be high. So when we think of a cancer center, we should always think it in a comprehensive management. It cannot be done by single modality. It's always multimodal. That is, you require more than one specialty to deal with cancer. So this is how it works. Radiation can be used either in early cancer, it can be used as a single modality. Only radiation may be enough. So, but as you know, in countries like ours, we, as he said just now, we see mostly cancers in the third stage or the second stage. So anything beyond the first stage, you require multimodal. Only when it is first stage, sometimes we can manage with only surgery or only with radiation. So radiation therapy is used in different way. Again, I tell you, radiation is a high energy X-ray. It comes from a machine like this, which is called a linear accelerator. It can be used for two reasons, radiation. One is it can be used to cure cancer. That means in early stages, radiation can be used to cure the cancer completely. So for common example, for maybe in Africa, just like in India, you may be having the problem of cervical cancer. So cervical cancer, even in stage 2, stage 3, is significantly cured. In stage 3 also, up to 40 to 50% of the cervical cancers can be completely cured with chemoradiation. So radiation can be used to cure cancer. Second, it can be used to reduce symptoms. So you know that cancer is a difficult disease. All of us know. In any part of the world, it's a difficult disease. All of us will accept that. But at the same time, because it is difficult, we cannot give up. So a patient's quality of life is important. So suppose a patient comes with metastasis in the bone and is unable to walk. So you need to make him walk. So his lifespan may be 6 months or 1 year. But he should see that 6 months to 1 year, he should have a good quality of life. So in that sense, radiation is used to reduce symptoms. Suppose if there is a bone metastasis, you can give one treatment of radiation and he'll be very much relieved of his pain. Similarly, if it is brain metastasis, he'll have a lot of symptoms, vomiting, disorientation, he can go into complications of hemorrhage in the brain. So there again, you can give radiation. So multiple factors are there where you give what is known as palliative radiation. Palliative means we are not curing, but we are controlling the disease, controlling the symptoms. Now the aim of radiation, it has changed enormously the field of radiation from what I practiced, say 25 years back, when we had cobalt machine, and today is a medical revolution in technology. Basically, engineers have helped us, or we can say biomedical engineers have helped us in developing so much research that from what we were giving radiation in a blind fashion, we are now accurately delineating it. So earlier what we used to do, if it is a cancer of cervix, we want to give radiation or X-ray, we will mark from outside, say 15 by 15 centimeters area to the pelvis, because we know the cervix is in the pelvis, uterus is there, pelvic lymph nodes are there. So we just mark depending on our knowledge of surface anatomy. But today, it is not like that. Because at that point of time, when we give radiation to the uterus or cervix, we used to always damage the bladder, we used to damage the small intestine, we used to damage the femoral neck and head, causing radiation damage to the hip. So all these lead toxicities were there, and people used to have fear of radiation. So radiation means always fear that it's a very difficult treatment, and if you give radiation, that means there is something catastrophic going to happen shortly. But things have changed very remarkably, because when I say this, when you see this slide, your terms like GTV, CTV, OAR, all these are terms which define radiological tumor size. GTV means gross tumor volume. That is what we see by imaging, by examination, by PET scan, all this we see gross tumor volume. CTV is what we don't see, that is subclinical disease. Any investigational tool as we have now cannot detect these cells, so we call it as CTV. And then organ at risk is like where we don't want to be radiation to be given. So earlier we had finding difficult to give radiation because normal structure also were there, all these were there. So now we want to avoid normal structures. It is like in the head and neck cancer, so tongue cancer. We give radiation for 6 weeks daily, Monday to Friday, every day 10 minutes, Saturday, Sunday there won't be treatment, it will be for 6 weeks. But all the time earlier when we give radiation to head and neck, both the parotid glands will get destroyed completely. And patient will have no taste for the rest of his life. We call xerostomia, and the parotid gland is gone. But today we have technology which we can clearly identify the parotid gland. We can identify each and every structure in the head and neck with imaging like CT, MRI and PET, and then give the radiation dose exactly to the tumor and the subclinical disease and avoid all the structures which you don't want to treat. So that is how technology has developed. So radiation is given in 2 ways. One is external radiation, that means radiation is given from a machine at a distance of say 100 centimeters from the patient. Patient will lie on the couch and radiation beam is given. One more is called internal radiation, that is called brachytherapy. So that is given in natural cavities like CS cervix, esophagus, endometrium, all these areas you can give what is known as intracavitary or brachytherapy. Now advances in technology has happened over the last so many years. So from basic simple planning with machines, now we have gone to 2D, planning, it is called. Then we call what is known as 3D CRT. Then we call IMRT, rapid arc. And we say now PET planning. That means biological target. Dr. also has showed you an image of PET. PET scan identifies metabolic activity. That means, say, if your tumor is 10 centimeters on CT scan, if you do a PET scan, you can see where exactly is the cells which are active. So out of 10 centimeters, 5 centimeters may be dead cells and necrosis. And there may be 3 centimeters which is real, the epicenter or active part of the PET. So when you give radiation, you have to give the high dose to that metabolically active part. So PET really gives us that advantage, and PET also has various advantages, like before a surgeon now do a thoracic surgery like esophagus, stomach, he always asks for a PET scan, because if PET scan shows metastatic elsewhere, he will cancel the surgery and go for, say, palliative treatment, chemotherapy or something. So PET scan has such a use. We have put it in our hospital 3 years back, and we found that how much change is there in our way we treat cancers. So unnecessarily before we are planning major surgeries or long period of radiation, but when the PET scan came and we have found out so many patients where they already have metastases, and there is no need to go for such a aggressive treatment, because already it is a metastatic situation. So our concept, thinking will change as per that. So now because of this advance in radiation, we are able to give very high dose. Generally in radiation, earlier they used to give 40 gray, say this is the image of prostate cancer. So 40 grays, then we went to 60 gray, then 80, now we can go up to 100 grays. So in oncology, whether it's radiation or chemotherapy, increasing the dose is fraught with serious consequences. It is not like antibiotics, where you can give 500 milligram or 1 gram, you can escalate the dose. Whereas in oncology, if you double the dose of chemotherapy and all, it will cause death, unless you are totally prepared for thinking it's a bone marrow transplant, otherwise it will cause death in routine practice. Same with radiation. If you increase the dose by 20%, it can cause severe side effects. Same thing, if you reduce the dose by 20%, you will get significant recurrence or relapse. But with this advanced technology where we can exactly pinpoint the tumor and see that the radiation beam is encircling the tumor only. So radiation beam is a light beam, but even then we are today able to make it even into a circle, like a coin. So this is the help of, as I told you, the engineering friends who have done it. Before, when radiation was simple, there was only one doctor and one technician required to treat. There is nobody else. The doctor will mark 15 by 15 in a pen, cervix patient. Next he will go to that machine and he will put on the machine and treat. He will tell 60 seconds to treat. That's it. He will put on machine 60 seconds. Today it doesn't work like that. There are too many people involved and it's a totally teamwork. And always I say oncology teaches you to work as a team. No ego in oncology. We have to keep our ego to the minimum. We have to agree to others' opinion. Otherwise, if you don't work in team in oncology, you always fail. Either whether it is a surgeon, medical, radiation, unless we work together, we are likely to fail. So it is teamwork, and there are many, many people now. So because there are so many processes, like patient positioning, when you treat accurately, positioning is important. Then some contour, we have to know your radiological anatomy well, because everything you are doing through imaging. So you should know where is the tumor, where is the muscle. So you have to check your radiology definitions and beam positions, all this verification. So it goes through such a big process. So instead of 2 people now, to start a radiation department, you need around 15 people. Medical physicists, planners, CT simulator, CT technician, all these people. And we have to be very careful also. So because any technology is a double-edged sword. You can make severe mistakes and it will create a problem. So sometimes I tell, if we are not well trained, it's better to go for old technology and treat simply. So be careful. So technology may look impressive, but always it is not as simple as we think, because those who have learned over a period of time, we know what mistakes we have done. So all this, and it comes with a cost, because you are using so many things for accuracy, imaging, CT, everything, all comes with a cost. All these are immobilization device, because you are telling you are treating the patients very accurately. So during the treatment, patient should not move, obviously. When he is giving radiation, he should not move. So these are all devices to see that they don't move. And now what we call as fusion. We fuse more than one imaging, like CT, MRI, PET scan, to see the size of the tumor. We may think it's 3 centimeters, but when you fuse all the things, it may be 5 centimeters. So it may be larger, especially when MRI is done to see soft tissue delineation, PET to see metabolic activity. So these are all in a head and neck case where you have to mark the optic chiasma, you have to know the dose, brainstem, all this doctors have to know. So it, as he says, as technology goes forward, we have to keep learning, and only then we will be able to manage with confidence. So this is with fusion with PET and CT and MRI based fusion, where you can fix one over the other, the image. You can put the CT image over the PET and then see the tumor, whether it is same or different. This is fusing PET. So PET scan shows metabolic activity. So if you plan with the CT scan, you may miss sometimes. So you have to do, may have to do PET and see exactly what is the tumor size and location. So it's like hitting a target in such a crowded place, so you have to be very careful. So for every patient, we use a CT scan now when it comes to the radiation department. It is not, as I told you, marking with the 15 by 15 ready-made boxes. We have to use CT for everybody. It's a lot of additional work, but you do a lot of accurate treatment and reduce side effects. So this is the area, suppose you want to treat the red color, maybe something near the nasopharynx, some lymph nodes there. And this is the parotid and the spinal cord. The blue is the parotid, green is the spinal cord. Now this is what we used to do earlier. We used to treat the whole thing, whatever is there. We want to treat only the red color, but we treat everything what is in between. So that we are causing a lot of damage. You can see the spinal cord is right there receiving. So spinal cord has a tolerance. Beyond that, if you go, you will damage it irreversibly. So then this technology came, 3D CRT, where we are able to do some kind of what you call modulation of the beam. Then we got this, what is known as IMRT, wherein you can really shape the beam the way you want. So then after that, now, always human mind, as he says, we try to think what else to do. After doing so many new technologies, still failure is quite high in oncology. We should accept that. So what do you do when you have failure? So people naturally are trying to think differently, treat differently. Now what was unthinkable before, as I told you, radiation used to be given, it gives given what is known as 2 gray per fraction into 30, 60 gray. Every day 2 gray, it's given. So it is never given above 2 gray, 2.2, 2.4 maximum, or now they reduced it to 1.8 to reduce side effects. But with advanced technology and accuracy, we started what is known as stereotactic radiation. So this stereotactic radiation is high dose per fraction. What we are giving 2 gray, we made it suddenly 20 gray. That means we increased it by 10 times, which was unthinkable, say, when I am studying or even 5 years back. So this we started what is known as stereotactic radiation, which is giving very, very high dose of radiation to the accurately sized tumor. So this has remarkably changed of how the actually radiation works. We are not sure even now what is the exact way it works, but it can just simply ablate the tumor. It will just disappear. It's unbelievable. So this we are using, we can't use it in all things. So we are using it in lung cancer. We are using it in liver mets or liver hepatocellular carcinoma, which is small. We can use it in brain. So this stereotactic radiation, which we are using in the last 3-4 years in our hospital, and since all of us are new while using this high dose, none of us know what is the exact dose the world over, how much you can escalate. Literature is very few. So all of us have to learn by trial and error, how much you can go. So we have done certain lung cases where we had extremely good successful treatment. We were happy, so happy that what lung cancer before we know, if you give radiation, it hardly moves sometimes. 3 centimeters will remain as it is. So with this kind of dose, we are surprised that it just disappears. But we realized 9 months, 10 months down the line, they were having severe complications, 2 or 3 of our patients, like tracheoesophageal fistula, and 2 patients died. So we got them control of tumor fully well, but because of toxicity they died. So this has happened everywhere. So we are tailoring and changing the dose. So all of us share literature because none of us are sure, because it's long-term effect. Radiation doesn't cause immediate effect much. You can manage it easily. What happens after 6 months, 1 year is the most important thing. So this kind of high dose radiation has really done very good in terms of controlling some diseases or tumors which we thought we cannot control. Recently we treated a patient of one of our senior cardiologists in Mangalore, his wife, who was 78. She had a maxillary antrum tumor. She was operated. After 9 months, it recurred 3 into 3 centimeters. So we give this stereotactic. Now it's almost, I think, 1 year, completely disappeared tumor. So this was unthinkable for a 75-year-old lady that you can give radiation, and it was not possible. Now since we are able to give very accurately, the side effect is so less, most radiation treatment are done on an outpatient basis. They are coming from home. Even they'll travel 3 hours by train, take treatment and go. So all this has changed the way we give radiation. SBRT is treatment of choice in inoperable patients and operable patients who refuse surgery, especially in lung. So lung generally is a disease of the elderly, 65, 70. So some of them will have medical morbidity and contraindications for primary major surgery in the lung. So these are all ideal cases for stereotactic radiation. So this is one case which we did. You can see the slides above on the right side, which shows that the metabolic activity in the tumor, and the lower images 3 are after the radiation, where you can't see anything. So this is how the high dose works. This was given, we did not give that 20 gray, which is very high dose, which in the literature reported that rib fracture was there. So you give so high dose that the rib is got fractured. So it's such a thing. So we reduce the dose to, as you see, 6 gray into 8 fractions, and that is also quite high. And we got complete response. This is another patient before the start of treatment, and this is a central lung disease. See, the problem while giving high dose in the lung is when the tumor is in the center, that is in the mediastinum cannot tolerate high dose. It's very, very difficult. So we had this patient with such a big subcarinal node, maybe 5 centimeters, and large tumor. After we gave radiation, within 3 months, this is the PET scan which is down, there is nothing there, which we cannot do with normal treatment. But, you know, we tried this high dose because we had no option for him, either palliation or 9 months later he died of mediastinitis. So for mediastinitis, there is no treatment with us. So it's high dose steroids, all that. But we realized that there is a limit where we can go to the mediastinum. Now we are stuck to some dose, which is our institution dose, where we have say that we don't go beyond this to the mediastinum. So with that, in the last 1 year, we have significant success, I could say, in non-metastatic lung cancer. That means stage 2 or stage 3B. We have got very good results. Patients surviving 1 year with no disease, which is unusual in lung stage 3. So these are all actually, most of these patients, we offered them even free treatment because they are not affordable. But we thought that they should get the better treatment. So to conclude, you know, oncology is a multi-speciality or multimodal management. Apart from what I told you, only it's the medical management. It doesn't stop with the medicine, surgery and radiation. We need a highly trained oncological nurse. We need counselor. We need religious people. We need family support. And always we say that at oncology, we can't stop at treatment only. Follow-up is very important. Follow-up care is required. Counseling is required. And in our field, we have to be with the family even with death and after death. So that's what we say. So this is how oncology is. It's a difficult field. But I think there is remarkable strides being done, as he says, targeted therapy and trying to convert it into a chronic illness. Live with the disease as long as possible, like in colon cancer. Give Avastin, give multiple now drugs, immunotherapies have come. People can survive instead of 2 years, maybe 5 years, 7 years with the disease, but with some form of treatment. So that is the way forward, I think, in advanced disease. And in early disease, I think with minimum toxicity, we are supposed to give treatment. Thank you one and all for your patient listening.
Thank you.